centrist party is likely to need help from the conservative Republicans to push the reform through.
Well, meanwhile, teachers and train drivers are dominating today a fresh round of UK-wide strikes. These aimed at securing pay rises that would ease the country's cost of living crisis.
It's exactly 10:05 a.m. Good morning and a happy new month. This is the month of February. This is the Great KBC, and this is News Check, a program that ensures that we keep you afloat on all the latest happening around you and around the country. My name is Njue, welcoming you for the next 2 hours. We'll be discussing topical issues and looking at the medical field and looking at the medical fraternity. They are a grieved lot. Why I'm saying this is the Kenya Medical Practitioners and Dentists Union has threatened to down their tools. Not only that, Kenya Union of Clinical Officers have also threatened to down their tools. Well, they have a number of grievances they want addressed by the government, of which they say some have just been dragging on and on and on. That is what we'll be focusing on this first hour. This time I take to welcome you. Well, talking about peace, we look at the Kenya political scene. It has been trading barbs between the government and also Azimio. There is also another war simmering that is between the medics and the government and the Council of Governors, and that is what is forming basis for a discussion this morning. And before we hear what they had to say, allow me to bring them in. On my immediate left, we have the Secretary General of the Kenya Union of Clinical Officers, George Gibore. Karibu sana, my friend.
Thank you very much.
Been a while.
For having me. Yeah, and Happy New Year.
Happy New Year as well. And every time that we are sitting and talking,
yes,
we are talking about challenges. We don't have some time. Maybe you can have a cup of tea and talk about some of the progressive or some of the things that the government has done in regards to that.
Yes.
That we will be discussing, and apologies for that. And just next to him, we have Dr. Kahura Mundia. Dr. Kahura Mundia is the National Deputy Vice Chairperson of the Kenya Medical Practitioners and Dentists Union. Karibu sana.
Asante sana, asante.
Before we delve into the challenges that the health sector is ailing from, let's first of all hear what the union had to say in regards to their discussion with the government and the Council of Governors.
Solidarity forever, for the union makes us strong.
Poor remuneration, disparity in doctor-to-patient ratios, unemployment, long working hours, and poor working conditions are some of the challenges which caregivers in the country go through.
Because you can't have a country where every month we have to go to the streets to get our salaries. I know counties where people are not paid for 2 months, where you have loan deductions on your pay slip and they don't remit to the banks. In CRB, doctors are like the highest number of civil servants. You don't have a medical cover.
This state has reportedly sunk some health caregivers into depression and poverty.
In a suicide note he wrote to the sister, Dr. Mogi described his desperations, not being able to find employment, and the sorrows of watching his poor family struggle months after completing his internship.
The recent case being reported from Kangundo constituency, Machakos County, where a graduate doctor took his own life on 23rd of January 2023.
Daktari represents the hundreds of our bright brothers and sisters who, after toiling for years training to be medics, have found themselves either unemployed or underemployed or working under precarious contracts that don't offer them any protection.
The Kenya Medical Practitioners, Pharmacists and Dentists Union, KMPDU, is faulting county governments for breaching the Public Service Commission employment terms.
Employ doctors, give doctors space to have discussions, remunerate doctors on time, promote doctors, and they need to be promoted just like all workers.
If some of the issues are not raising here will not be implemented, we'll shut down. We'd rather stay home with our colleagues than pretend that we are working and we are just watching patients die.
The KMPDU now says that most of its members are faced by a myriad of challenges which are contained in the 2017 collective bargaining agreement. It is for this reason that they have given the government a 60-day grace period to honor that CBA, failure to which they will put down their tools on 5th of March 2023.
Will be retired from service. For safety reasons, it was decided the station...
Following what that report has talked about, the 2017-2021 CBA, collective bargaining agreement. Kindly bring us up to speed, Mundia.
Well, thank you. Well, we had an agreement with the government in 2017, that is following the 100-day strike. And this was of the issues of accumulations of disgruntlement in the health working space. And parties sat down and agreed. And out of that agreement, we decided how much should be paid to the doctors, what are the working hours, and the number of doctors who were supposed to work at each of the facilities. But 5 years later down the line, we are yet to realize the agreement that we signed as parties. So we're finding facilities with very few doctors, very few health workers, and with that, you're having the persons who are working at the ground being overworked, and that affects the amount or the quality of work that's supposed to be going to the patients. So with that kind of working, you're having persons getting a lot of mental strain, and that is probably leading to some of them getting to what has probably recently happened. I condole with the family of Dr. Moki, and he's one of the few colleagues who unfortunately have been affected by the system. Having very few doctors working in the healthcare facilities and having many doctors graduating and not getting to be replaced or employed in the sector that needs them, it leaves these persons exposed to a position whereby they don't know what to do. Because as a person who's recently graduated, venturing out in entrepreneurship and starting out a health facility, it is not the easiest of jobs to do. And a country that is not having adequate personnel to provide these services, it's very surprising when you have qualified workers staying at home watching TV, when you have patients queuing and unable to access care, and the government, they're just watching. So it's unfortunate that one of us succumbed to these pressures, and we will really implore the government to take charge of what we agreed on in 2017 and implement the few clauses that remain unimplemented.
So you're saying that the government has met you halfway already? But more needs to be done?
More is still to be done, especially on the aspects of employment. Scarily enough, we have the basic salary component, which was never implemented. So we agreed like how much the doctors were supposed to be remunerated, but none of the governments have actually implemented that particular clause. So we went in court in 2020, and a judgment has been passed.
Okay. Apologies, we seem to be having some issues with your microphone. Let's first of all have a look at it, and then we'll be getting back to you. And also just be preparing. You've talked about shortage of doctors, and we have graduates graduating each and every year. And also we had the Cuban doctors. All right. Marinate on that. George,
Yes.
In your union, you still also are claiming some of this. From what I've heard from Dr. Mundia, is that you are also having or facing almost the same challenges. What are some of the challenges the Kenya Union of Clinical Officers or Grievances have brought about to the government and the COG?
Okay, thank you very much, Ben, for having me for the first time. And of course, I want to appreciate that you are able to call us so that we can highlight on the issues that is really affecting the healthcare workers and by extension affecting the Kenyans. And I need to say that, you know, when you have a problem, always you must devise a structure, a framework to address that problem. We have a problem as a country. We have a very fragmented health sector where counties, as per the constitution, are supposed to do some specific services as envisaged under the fourth schedule of their constitution, and also the national government has a certain function. Now, if to mention, to be specific, is that the referral and the constitution say national referral services remains with the national government. Policy framework remain with the national government. When we come to the counties, they have been given promotional preventive services and other services that include now facilities under the preventive services. But you'll be surprised that by virtue of how we handle devolution, we fragmented the system, that the health system is not able to work synergetically to offer the services that Kenya need. And to that extent, the healthcare workers who are critical component to offer services to Kenyans are remaining complaining all the time. And this is more of you as a police officer taken to fight with a gun that cannot actually discharge. So the healthcare workers have a bigger problem, and this bigger problem is affecting the Kenyans. Now, since devolution, we have had more than 100 strike. To be precise, more than 105 now strike. If this one will materialize, we'll be going to, because there is already a strike which has been announced. And what are the ailing issues? What are the issues that are there recurring year in, year out? We are talking of understaffing. We are talking of lack of drugs in our facilities, and we talk of a lack of funding in the health sector. Now, when you don't have the funding, you can't employ, you can't do infrastructure, you can't have technology that is invest in terms of getting the equipment that we do need, and you cannot be able to ensure that you implement, including the CBA that we are talking about. You cannot be able to post interns, as we have been also raising those issues. Now we have people who the county and the national government are trying to handle now the health sector in a piecemeal way. Last year during the COVID time, we employed staff on contract, and it should be noted that is against the existing provisions of this country, and including the international charter, where if you have people of equal qualification offering the same services in the same environment, you ought to treat them equally. So they are discriminating against them. We have over 10,000 healthcare workers under the same program, and we have seen different discrepancies in terms of declaration by the Minister of Health saying they want them on PNP because they are the one who actually employed them and seconded them to the county, which I believe that is a key component, a provision under the Constitution where the national government has a responsibility of capacity building to the counties. But the counties now are saying, we want these people and we want this budget to continue putting these people on a contract, and which we feel that this is not how we need to handle the health sector. We are actually escalating the problem that we have, because by virtue of our politicians who make decision on what should happen in the health sector, they always make wrong decision because they don't seek services in our health services, in the public health sector. And this is why the healthcare workers continue to lament in, day out, because why should you contradict a national government saying this way and you say this way? And that is why you'll see also counties are running away trying to have every facility, every county want to have a referral hospital, which is not wrong. But the referral facilities as per the Constitution, there is nothing referral services under the county. All the referral services for the country, because you don't choose where to be referred. It is supposed to be a national government services. So once we mishandle that and they continue now push and pull with the minister and the county, we continue remaining in the same problem as I have mentioned a number of them: understaffing, underfunding, and also lack of the equipment that we do need to handle the services, and the lack of priority. Because when you say about that, you look at, we are talking about universal health coverage. It needs an intense and a robust funding, which is sustainable, and a clear structure on where we want to go as a country. But we continue talking about it, continue working and having very good policies, but implementation is a problem, because the people who are supposed to be partakers of that, who are supposed to implement the healthcare workers, are not involved. And do not actually understand where the country is going, because we ought to put on the table what is it that we need, which at step 1, step 2, step 3, so that we move toward that. So to where I stand, the healthcare workers continue to lament because we have more of what I can say a failed health system that is non-responsive to issues that are affecting healthcare workers and the Kenyans at large.
All right, George, if the government right now says, because we want to avert this strike, we want to meet you halfway, are you willing to call off your strike?
I want to say very clearly that strikes comes as a last result. Before you see any union calling for a strike, is that they have attempted very many avenues, but nothing is coming out. Now, I want to take back that we have a new government that came with a lot of promises, and I have read very well the Kenya Kwanza Manifesto. If it is implemented, is a brilliant idea for Kenyans to celebrate. But immediately after the election, you wonder whether there is someone who is more of a dream carrier in that ministry to ensure that we can be able to implement what we promised Kenyans. Now, we continue lamenting, writing letters. They are non-responsive, never engage, never want to talk. So once you don't talk, and of course I want to say, like when the doctors gave their strike notice last year, December, that brought forth the posting of interns. And the CS went on her Twitter to say that this was as a result of the strike notice, and therefore we are celebrating posting. It is more of inviting people to go on strike, because the strike, it is only on a strike that they respond to issues. That is her statement. It is not our statement.
And let me hear from Doc. What about KMPDU? What does it take for you to call off the strike? Because in December you had already called for a strike, but in January things seemed a little bit rosy. But now you feel you got the short end of the stick, and that is why you are giving maybe ultimatums. We need this and this and this done. Where do you want the government to meet you halfway? Because let's be very honest, some of these issues that you're raising require a lot of funding, and looking at the economy right now is not quite doing quite well. Where would you want the government to meet you halfway?
Okay, I will begin from the point where we have two levels of government, the national and the county government. And like we all know, the national government at the Ministry of Health, it's in charge of planning matters and policy development in matters healthcare. Doctors and all healthcare workers are a critical resource to any nation. So you need to plan, and plan well about what you need and how many persons you need to specialize and how they're supposed to be distributed across the country. So as a country, when we fail to do that, we fail to budget, we operate on, today we want to post this group, tomorrow we will not post that group. It eventually causes a lot of distress to the employees who are expected to be absorbed by the system. So when this happens, you now have all this disgruntlement that's coming up, because we don't have a standardized mode of payment for most healthcare workers in the country. We have doctors, particularly speaking about doctors, we have doctors being differently paid at the national level, serving the same duties, same hours at the county level, at the county governments, but they're paid differently. That is not proper, because the SRC is supposed to oversee harmonization and uniformity of all these standards, but whatever they come and tell us is something that doesn't make any sense. So as a ministry, probably the Public Service Commission and the SRC, they can come together and harmonize all this. Now, aspects of budgeting can go to the Ministry of the Treasury, and they can plan how to absorb these persons and how to get persons straight from school, whether they are clinical officers, doctors, nurses, how they're supposed to be absorbed by the mainstream system. Because when you leave them out there, they end up not serving the Kenyans that we want. We want to achieve universal health care. We cannot achieve universal health care because we don't have enough workforce. If the workforce that is currently existing is overworked, you will still not realize the satisfaction of universal health care. So if you have to get universal health care, employ enough workload, enough workmen to provide those services that you want.
And talking of workload,
yes,
let's go back to my earlier question on the Cuban doctors. I do remember there was hue and cry from the medics asking, why would you even be thinking of going to any other country in the world to get medics, yet we are having medical doctors churned out from university year in, year out.
Thank you. Now back to that. You see, we had that CBA agreement. It's mostly about employment issues. So some parts of it are not implemented. And we, following the December strike notice, we have been in talks, and we are still expecting reports from the persons who have been tasked to do that by the end of this month. They're supposed to submit those reports to the conciliator. So we hope the multi-agency bodies, they will do their work, and they actually identify the real issues, and we can get to have these issues resolved. Failure to which is why we are giving the strike notice. Coming out the Cuban doctors, Vision 2030, that document had an aspiration for Kenya to start exporting doctors or
not
Kenya
importing,
exporting, or Kenya becoming a medical tourism hub. So these are areas that we can actually develop as a nation. But when we don't plan and we train and dump, we don't get to realize that. Cuba is exporting to us. While we have enough workforce to absorb locally, and if we still don't have enough for ourselves, we train more. And when we get to train enough, we can get to export these numbers. Because other states also need doctors. So it's something that the country can look at it as a resource that they can train and use well for itself and for other nations if the country is designed to do that.
So as a vice chairman, you're saying that we have enough doctors. We do not even need the Cuban doctors. We have sufficient doctors to ensure that the health system is in an order that we can even export, just like you said.
Yes, we have about...
And the Cuban doctor, my second question, the Cuban doctors, are the terms and conditions that they are operating in right here in the country the same as you, as a Kenyan doctor?
Well, there's about 3 issues there. Whether we have enough numbers. We have about 9 universities, all training doctors. We have about 2,000 thereabouts coming from the schools.
Every year?
Every year. We are yet to attain the numbers that are recommended by the WHO. But these numbers, they are abstract, yes, but there are particular skills for... There is a general doctor and there is a specialized doctor. So there are ratios for the specializations that should also be met for each level of government. So you cannot just say we have attained the numbers. We are yet to attain the specific specialization numbers. Because if you want to get the highest standard of healthcare, even after schooling, you have to upgrade your training. So that's another aspect of getting the numbers the right way. There's the general numbers and the specialized numbers. Now coming to the aspect of payment on discrimination and Cuban doctors coming in.
Yeah, because there is an aspect of discrimination in your petition, and also with KUCO, we'll hear from George.
So there is that aspect of having in foreigners coming trained just like ourselves, same years, same experience, but when they were imported, they came in and were placed at higher job groups than the locals, which is a little absurd, because you have a regulator which has standards, but I don't know how the standards were bypassed. And these persons came in without even knowing the local languages, and we had to hire even interpreters for them, which is even increasing the workload and the security as well, and housing. We don't get housing. And if we do, just a few persons in the professions get housing in the government sector. We're given differentiated housing allowances, so persons working in Nairobi, they paid more than the persons working in Mombasa or persons working in Turkana, because the argument is the house in Turkana is cheaper and you should not be paid as much as that. So nothing will attract you to go to Turkana if the housing is poor and the housing allowance is also poor. No doctor will want to go to Turkana. So for SRC, Public Service Commission, the government, if they want to harmonize distribution of healthcare workforce, they have to standardize the rate of pay. If you want to attract someone at Maralal, pay them the same rate as the person in Nairobi. So that if I want to make a saving, I'll be better off working there and serving Kenyans and attaining the best. Now, Cubans were brought to probably go and fill up those positions, and they were given the best terms that we are always asking for, and we're not getting.
And the same terms that are making doctors not go there, but they go there with even higher salaries than the doctors here in Nairobi.
So that's not proper. So
that's the discrimination you're talking about as well. George, there's something that you wanted to add, and still on it, I want us guys to touch on counties, because both of you have touched on devolution and counties. We know the medical, health is devolved. But from what you guys have talked about and what is on the ground and on paper is that we are having a hybrid system. I'm talking about a hybrid system because if at all it is devolved, you're talking about counties and governors dealing with governors. But when it comes to referrals and policy making and all these things, they are reserved for the national government.
Yes. But listen, and any Kenyan listening, listen carefully. When we say health is devolved, is a misleading statement. Health is a very huge system. We going by the WHO, which around 6 building blocks. We talk about health infrastructure. We talk about commodity and technology. We talk about human resource. We talk about funding. I remember the others later. If you look about that, Now, the component of infrastructure, there is health service also on the same. There is what we call now, look at what the county is doing. County says, actually that is the statement they normally use to intimidate the national government, that health is devolved. Look at what we call now the health services. It is the health services that was divided under the constitution and some of the infrastructure. Now, when you talk about referral services, where does referral start?
At the county level.
At the county level.
Yes.
But that service is actually has been preserved for the national government. That's a fact. Now, when you look at promotive services, which is preventive services, is now at the county level, which is the primary law facility. Now, that is the service that they have been given, which include ensuring that people are getting immunization, preventable, sensitizing people on how to prevent communicable diseases, and a number of those. So when you look about that, it will tell you that there's a mix of what you use. Now, who is funding health? It's the national government. The national government has the resources. So when you look at the county now, they are the one running, and every resource they are getting, they run to put brick and mortar, which they call development. But facilities built there without putting into it what now the components that bring about the services, it is actually zero-sum game. Look at what the NMS did. How many facilities did we bring about?
Many. Close
to 24. Did we employ healthcare workers? Are those facilities functional? And even the existing facilities that we have in this country, actually going by the WHO, our facility, that is a facility, especially hospital facilities, they are now meeting the WHO recommended facility per population density. But if you look now, going back to the healthcare workers, we have what we call staffing norms, which they are internationally recommended by the WHO, that you need to have, like as the clinical officer, you're supposed to have at least one clinical officer attending to around 800 Kenyans. Now we have close to, now currently what is there is that 3 clinical officers are attending to close to 12,000 healthcare workers, patients. That is the ratio now which we have. Actually, if you go to the doctors, there are now 2 serving 10,000. You see? But if you look at now, because in the health sector we have close to 17 in our country, close to 17 regulated or rather professionals that serves in that healthcare. Wholesomely, we are supposed to have, according to the renewed standards, 45 staff serving 10,000 population. Now currently, we are doing less than 6% in most of the counties. Only 11 counties come close to 10. What does that one tell you? We are in dire need of the staff. The staff we have are being overworked. The staff we have are not being well remunerated, even when they are understaffed. So what you are building is a system that is not speaking to the real situation that we have. We continue complaining of what is happening, but we are overworking these healthcare workers. When we raise issues, we agree with the government that yes, this is what we want to do, 1, 2, 3. They have a scheme of, a CBA, that is a tool that is there to provide for terms of engagement, terms of working conditions, and what the doctors need. For us, we have been negotiating a CBA for 4 years. The government really want not to move. Whenever you want to move, they just come up with any other issues. They are not willing to engage. And that is why it is not surprising that they run away to bring people in this country and pay them more than 2 times what they are paying their own. So indeed, even if we were to engage all the staff, including the clinical officer, let me specifically talk to clinical officer. We have 27,000 registered clinical officers who are ready to work. The government has only engaged 7,000. So 20,000 are outside there. Even if we engage the 20,000, all of them in the system, we don't have enough. looking at the population where it is over 50 million. So Kenyans must get to know that we have a government that always will speak from the rooftop, but they never implement anything. Like when we say employ healthcare workers, does the union take credit? No. It is them the next day when they are going for campaign, they will say, I employed healthcare workers. When we say invest in infrastructure and bring drugs in the hospital, ensure that our primary health facilities are functioning optimally. When it functions, it is them who take credit. It's not the union.
All right.
So who are we working for? For the Kenyan. It's not even for the healthcare workers.
All right.
Yeah.
There's another issue that you raised, that your statutory deductions are not being remitted.
Yes.
This is what? This is more or less like a government that feeds on its own young, because if you can hire doctors from another country when there are doctors here in the country, you do not look at the plight of the doctors and all the medics, and now you cannot even remit the little that is mandatory to be remitted. And do you believe the Health Commission, it had been mooted in the BBI, and also the Kenya Kwanza Manifesto gives some goodies to the medical fraternity? Do you think if these things are actualized, we wouldn't be hearing solidarity forever as you dare the government that you're going for a strike?
Well, it's very distressing. I would still want to repeat that the US, UK, and let's say maybe Middle East, China, you cannot just go there and work or get a job as a doctor. It's not that easy. You have to do exams or even go to school, because they consider our training. Well, we train our persons really well, but they have their own rules as to how they want to absorb external workforce. Here we absorb external workforce, pay them regularly and pay them well to go to the far-flung places where we don't want to pay our own, who are willing to go to those places. And even a choice was not even presented to the doctors or even healthcare workers. We just had, there's an importation coming, we went to court, it was proven against us that we did not have any evidence that Cubans were coming. Next week they came in and they were posted and they've been here. Now we have rogue officers, accounting officers, maybe from the executive sides of the county governments. Doctors are only paid net salaries, or let us just say not doctors. Most persons working in the county government, either from issues stemming from the treasury, they're paid net salaries. What that means, whatever is net on your payslip is what you get. Any other thing that is loaded on your payslip as a check of debt to the government or to other agencies is never paid. Reason being because of issues of either mismanagement, money is coming slow, we have loans not getting paid. So you are listed as a staff on CRB for non-payment of your loans.
That has already been deducted.
You're already working for, that should have been paid regularly by the employer. So you end up, you're being listed. You follow it up, you're being told you wait. So you get blacklisted on CRB. You go to seek your tax compliance certificate. You're being told you've not remitted your taxes. You even wonder now. The county employer, the county government is the employer. They have not remitted taxes to KRA. So the issues of reconciliation, you cannot get your tax compliances. You go to NHIF, you want to seek service insurance coverage, you find you are not updated. That means you're blocked from accessing services. Last week, Nairobi County government, they have a budget, a bill of about 1.2 billion. On NHIF, they had claimed that was not their bill because it originated from NMS. It's NMS that was supposed to foot the bill, which I don't know how it was not paid. Now on transition, there is now Nairobi County government. So all healthcare workforce, not just healthcare workforce, all workers in the county government, they are suspended from accessing that benefit.
You're telling me you're a Madek, but you cannot access health care services because your NHIF has not been paid, and the money has been deducted.
It shows it's been deducted, but it's not been remitted to the person providing those services. So the other agency just decides to suspend all of you, and that's why last week we had declared a ghost law in Nairobi, the whole of Nairobi, and that doctors will start picketing the whole week. Because it's not fair as a clinician to provide services that you cannot access as a provider.
And do you believe that the Health Commission, that it's an idea that had been mooted? Do you believe that maybe it can change the tides?
How it all now goes to the Health Commission, that's another discussion altogether. So you have all these multiple issues. The only thing that the county governments are focused on is getting you the pay slip, the net salary. But the other issues on tax compliance, they're not paid, NHIF not paid, other benefits not paid, SACCOs, banks not paid. Now, Health Service Commission, based on what we've observed from the two levels of government, national and county governments, and as per the Schedule 4 of the Constitution that describes the aspects of devolution, a human resource was not, it's not there, it's not listed there. It's impliedly devolved. There was an argument about it, but it never got concluded. That implied devolution of the human resource, we thought maybe, because the two levels are always in disagreement and all these issues may want to be harmonized, it's better to come up with an agency like Nigeria, like Uganda. They have a health service commission. That as much as devolution wants to go in the other aspects, but the particular aspect of human resource and all these issues of disgruntlement, if they can get centralized by one body, not just doctors, clinical officers, nurses, all those persons who are supposed to work in the healthcare ecosystem, they get managed centrally. And counties can apply when they need workforce. At the same time, this agency can advise you need to have this person, so they post them down and harmonize and have standardized working terms at all levels of government. Because you have that administrator at Lamu, that administrator at Tana River, that administrator at Kisumu, they're all in their own world. They don't want to refer to the schemes of service. They don't want to refer to the CBA. They don't want to refer to the MOH guidance. They don't want to refer to the PSC. They don't want to refer to SRC. They're on their own. And every day challenging all these persons, 47 of them. This government comes in, they're replaced. Another government comes in, they're replaced. So you have to keep on having these conversations. So it's very annoying, very distressing, and very time-wasting if you probably had one agency with the institutional memory to manage workers as they should.
All right. And because of the interest of time, I would like you also to focus on what, of course, there is a priority of how you want some of the issues addressed here. And still while at it, looking at what we have, we had a medical emergency a couple of days or weeks ago, the cholera outbreak. And we had a pandemic, that is COVID. We still have it, yes, but at least we have been able to manage so far. What are some of the lessons that we can pick from this? And do you believe that in case of another epidemic or even a pandemic, do you believe that we are well prepared to handle it just like we did in COVID?
Yeah, thank you, Ben, for that question. But allow me start from where my brother has left it, so that I'm able to come to the other side. And just say that it is very difficult to engage counties and the national government. These are 48 entities, and all of them, individuals who are heading this department are individuals who just believe on things that you sometimes wonder. As I'm speaking, yesterday I was in Makueni, and I met the County Public Service Board at Makueni discussing just implementation of a scheme of service, and they're hesitant. You find that because of that, some counties have never promoted since the devolution.
That is more than 10 years ago.
Yes. And because of that, every county employs on different structure. And remember, we said that policy, which the SOS, that's a scheme of service, is also a policy document, is a reserve of the national government. Some counties now proposing even to have their own. This confusion is there, and the body that are tasked to do this, like the Public Service Commission, is supposed to to actually take lead and provide guidance in that sector. They are still mum. They are actually mute. When you look at the SRC also, when people are being employed differently, paid differently, they are mute. Actually causing the problem, I have seen a compendium that they have issued, eliminating and proposing to eliminate a number of payable allowances to the healthcare workers. It is going to be the biggest chaos that we have never seen in this country, because people are suffering. People are actually sick. We are not able to get even the services that we are supposed to get. And you tell them that you want to take away what puts the food on their table. I think that's critical. And I wonder, when even they recommend that house allowance people to be paid around 4,000, where on earth will you get 4,000? A house for 4,000, an officer to stay. And when we talk about equitable treatment and parity in terms of treatment, when we are working in the health service, in like a hospital, and we are exposed to a certain danger, the danger does not choose who you are. It doesn't choose whether you are a man, whether you are a woman, whether you have a degree, whether you are a professor. This danger is the same and the people must be treated the same when it comes to the risk allowance. That is very critical. Now, coming back to where you asked whether we have learned from the COVID lesson, and now that we have several cases reported, and actually we have lost people because of what now we call cholera. It is good to note that our country always react. We do not plan to ensure that we are proactive. We always wait to react. And when we wait to react, we lose people and we don't always manage. We run after the conditions. So indeed, cholera is here with us. The health sector is not well prepared to handle, and that is why several months down, we are actually more than a month now, we are still reporting of cases of cholera, like here in Nairobi. So we need to look about the whole system that is contributing to this, including the environment, then that is addressed as a wholesome, rather than just piecemeals of the approach that we always use as a government and fail to tackle the problem that is affecting Kenyans.
All right. Daktari, again, what would you want prioritized? And also, kindly touch on the mental wellness for these doctors, because we have seen some of the doctors take their life and some are wallowing into immense depression.
Thank you. Well, what I'd wish the government would do, we have submitted a new proposal of a CBA because we are in another cycle now. And in this new proposal, we have included new aspects of what you've learned, what is happening in the healthcare space. So this CBA is supposed to advise all stakeholders, all level of governments on what the workers in the healthcare space need. So there is something that's very key. The aspects of employment, unemployment, underemployment, discrimination, all those are captured in there. And we wish all the agencies get to focus on it and resolve that particular issue. On the aspects of mental illness and stress at the workplace and harassment, Kenya ratified the other year a convention on harassment and violence and safety at the workplace. So we'd want to have all facilities, establish places where workers, whenever they are distressed, whenever they are having issues about their workplace, can get to be attended to, and the fairest and most confidential of places. So it's a proposal that we seek that our employers will take in and provide these services, because a sick caregiver cannot provide care to persons who need their services. So we want persons providing services to be mentally stable and to be accorded services whenever they need this. More particularly, there is something that's more important that we have failed as a nation to do, staffing norms and standardization. That we've also captured in the new CBA proposal. The Ministry of Health had a task to do it. The Kenya Medical Practitioner Dentists Council had a part to take on it, and we hope that with all that, capturing it in the CBA, we'll get to have all that harmonized in a way that brings us what we want as a health care.
All right. Thank you so much. Well said.
Thank you.
Dr. Kahura Mundia, who is the National Deputy Vice Chairperson of the Kenya Medical Practitioners and Dentists Union, and just next to him, George Gibore, who is the SecGen of the Kenya Union of Clinical Officers. They are laying it bare what exactly they want. The two unions have threatened mass action, industrial action. They have talked of strikes if the government does not meet them halfway when we come to their demands. Thank you indeed so much, gentlemen, for making time. And thank you so much, Daktari. And from there, we are looking at gender-based violence and FGM. Where are we? What about the safe houses? What are the statistics? That is what we will be looking at in the next hour after this quick short break.